this one. Again, this is our slide set that we always share with our all of our partners in the incident command structure. But this gives you a good overview of what our metrics are doing. And as you can see, we've now crossed 120,000 in terms of our total number of cases. It's actually at 121,000, giving us an average, a 7-day rolling average of 44 cases per 100,000. So that is really high. We haven't been that high during this whole surge. So unlike other counties that are now starting to plateau and slow down, we're really not seeing that slowdown yet. The number of fatalities is climbing quite quickly. It's now at 1,838. So we've added dozens of fatalities in the last few weeks, unfortunately. In terms of what's going on at the hospitals, we have 408 hospitalized patients across our healthcare facilities, including 92 in the ICUs. That again represents record high numbers. And those are just the COVID patients. Remember, there's just a ton of other patients that are being seen. I had the privilege of working in the emergency department earlier this week. And I saw people that, were hospitalized because they missed dialysis, because they had a snake bite, because they had motorcycle accidents. So, the normal injuries and illnesses that go on are still continuing. And in fact, they've kind of come back to normal or even super normal levels for this time of year. And then on top of that, we're dealing with this COVID surge. So the combination of those is what's really impacting our hospitals and really challenging them to try to deliver the best care that they can. Working closely with our hospital partners, if Dan Lynch is on, I think he can give us an update about all the things that he's doing in partnership with the hospitals and with our pre-hospital system to make sure that we're using our resources the best way that we can to fulfill the needs that are presenting themselves. There are staffing shortages that continue. Some of those shortages are slightly ameliorated by a few dozen traveler professionals that have come into town, mostly nurses, some physicians that have come to help. But it remains a large unmet need for the whole county, and the hospitals are certainly impacted. And we continue to try to find them resources just by using state and federal mechanisms to try to get them the resources that they need. So that work is ongoing. I won't belabor it because I know that most of you are not working at the hospital level, and those of you who are already aware of all of the nuances of that. But I think everyone does deserve to know that the hospitals remain critically impacted. And whatever we can do to help offset this COVID surge and get through it would certainly help everyone. The best way that we can do that is with all of the layers of protection that we have been promoting, especially with vaccines and masking. Really vaccines are going to be the way forward for the long term. But in the meantime, whatever we can do to encourage masking in our patient populations will help quite a bit as well. In addition to just having people stay home when they're sick and not spreading it to other people like their close contacts and their colleagues at work. Just more metrics here. So if you'll recall the blueprint that we were under until June, that really color coded what our performance was doing. And although we're no longer in that blueprint officially, we still like to compare things according to that color code. And right now we're in deep purple. That's shown by the adjusted case rate being 43 and the testing positivity being relatively high at 9.8% as well. And this shows you that, when the testing positivity is more than 8%, we really have to worry. When the daily new cases are more than 10, that means that we're in the purple. So the fact that we're at 9 something on the positivity and then greater than 40 on the new cases, that really puts us very, very high in terms of where we would land in the purple. We would be in the deep purple, and we've been there since August, since early August. And we're probably going to continue to stay there if the state projections are accurate through the month of September. Here's how we're doing compared to the rest of the state. So again, this stings a little bit because you could see that the blue line is California, and California did have their surge, and now they're kind of dropping off across the state, whereas Fresno is just continuing up and up, and that's really hard for us to watch and obviously experience, just because we know that our population is more vulnerable, less vaccinated, and we have much fewer in the way of healthcare resources compared to other parts of the state. In terms of vaccinations, again, the demand is going up, which is good, but it doesn't seem to be going up fast enough. So whatever we can do to help reach our goal of getting to vaccinating, in the 70 to 80% range. Right now, we're at 52% of our population. We really had a great conversation during our media session a couple of hours ago from a gentleman who actually caught COVID and is now very remorseful. And he really told his story, which I think, isn't appreciated by the general public enough. I know many of you have similar stories about your patients or even your relatives and your neighbors who have done, an about face when it comes to vaccinations after having a close call or a personal illness experience with COVID. Well, this guy, he's a nice gentleman, and he basically, dismissed COVID as a disease, and then later dismissed the vaccinations and their value until he himself got COVID. And then his whole family, including his wife and children, got COVID. And one of his really close friends' dads ended up in the hospital and is still in the hospital, hospitalized. And now he's very remorseful. The reason that I bring that up is to share that what really changed his mind was getting sick with COVID, but really even that didn't really sell him on the vaccine until he got a chance to talk to a physician. And it was a physician that he had known, he had a relationship with, it was a family friend. And that physician, just having that one-on-one conversation with him and really spending a few extra minutes with him to answer his questions and really respectfully hear him out, really allowed this gentleman to ignore all the misinformation and then make the right decision when it comes to vaccines. That's why I'm sharing this story, is because I think that's where we are. The white coat really helps. And this is the moment when the white coat is really going to win over a lot of people that are being distracted and confused by the misinformation that they're seeing on the media and on the social media and hearing from their friends and neighbors who are also misinformed. We just need to cut through that. I mean, there's a real problem with science communication in this country on a general level. And that's just like a chronic misinformation pandemic that has been decades in the making. But that's what's really leading to the low vaccination rates, in my opinion. And we just need to cut through that and acknowledge that it's there, but then do whatever we can in our power to actually counsel our patients and just to look them in the eye and very seriously tell them, this is about you and your family. This is not about politics. This is not about, some larger control or conspiracy theory. This is really about the safety that we can give you and your family through these vaccines, and really giving them a chance to respectfully engage you in conversation. Please invest that time. We know that you're busy. We know that you have a lot on your plate. But at this point, this is what these patients require of us, is to have our physicians and our medical professionals step up and really have those personal conversations. So please take that to heart and do what you can to try to engage your communities. If you're active in civic organizations, faith-based organizations, schools, businesses, really now is the time to step up and use your role as a physician for the common good, and just allow people to, engage you, perhaps be skeptical, skeptical and express that skepticism. But, do it in a way that they basically get good information at the end of the conversation. So that they don't feel like they're just scrolling through social media and more confused than ever, because that's what a lot of these patients are. And we can argue all day long about whether this is their responsibility or our responsibility, but at the end of the day, we're all suffering until we get to herd immunity. So I think we need to do what's in our wheelhouse, which is educating and counseling our patients and making sure that they have good information, and obviously beyond information, that they have access and that they know exactly where to go with the My Turn website. And Sim can drop that My Turn website if you're not familiar with it. It's never been easier to schedule a vaccine or even a booster for people that are ready for that. And I'll talk more about boosters in a little while. But really, the access piece, so much has been invested, millions and millions of dollars, hundreds and thousands of hours have been invested in making sure that people have access. And it's really just a matter of connecting people to those resources and lowering those barriers and nudging them to go in the right direction with vaccines. So please help us with that. Just more data in case you're curious. We're doing really well with residents over age 65. That's not really who we're worried about anymore. It's really the people in their 30s and 40s and even school-age children who are not meeting that 75 to 85% goal. And here you see kids, and they're at best in the 40%, the ones that are eligible, and some in the 50%. But we know that there's many more teenagers and adolescents who could benefit. In fact, there's hundreds of thousands more who could benefit. And so we really do need to reach out and work better with our school age populations to make sure that those parents, those families understand the value of vaccines, and that whatever we can do to get those teenagers and adolescents vaccinated will really help control outbreaks in our school settings and in all of our extracurricular activities. So that's a little bit of the data side, and all of this data lives on our dashboard, so you don't need to hunt for it. If you have a specific question about a specific group or demographic, let us know, and we can do a deeper dive or just point you to the dashboard that has that information. But again, a lack of information should not be a barrier at this point. We have so much information. The CDC MMWR just came out this morning that really shows what we've been observing in California for the last few weeks, which is that the vaccination protects you 5-fold against infection and 10-fold against hospitalizations and death. And I'll try to link to the MMWR when I send out the notes. But that, again, just adds more ammo to this story that vaccines are exceedingly protective, and they're really the way that we need to move forward in protecting our community. And it looks like Sim was able to link to the story from that gentleman. His name is Bobby Marina, and it was a really nice session. I really appreciate him coming on and having the courage to really just and the humility and the courage to step up and describe his story. All right, are there any questions about that or anything else that I can comment on when it comes to data? All right, let me share my screen in a couple of ways. And just share with you a couple more things that we're doing. So this is a memo that Dan Lynch shared with us. And this is the CCEMSA, which is the Central California EMS agency. This went out to basically all interested parties, meaning clinical providers, hospitals, EMS, et cetera. And Dr. Andrews and Dan Lynch basically said that the assess and refer policy is still in place. However, transports from state prisons and the Coalinga State Hospital will be exempted from that assess and refer policy. I'm just sharing this as an example of the very tight calibration that's happening to try to make sure that we really do match needs and resources on a day-to-day basis. So as you'll recall, the whole reason that we put in the assess and refer policy was because we really didn't have enough ambulances or beds in the system to transport every non-emergency to an emergency department. And so we really had to make some decisions about who to triage. And if patients were deemed to have a non-emergent medical condition that could wait to see a doctor or an urgent care clinic, then they were offered that option. Later, that option became a requirement, and that's still how it stands in place now. But then that requirement was changed a little bit to say state prison facilities and the Coalinga State Hospital is exempt. So just to give you an example, like this is what's going on every single day with our EMS system, is they're really just matching needs to resources and making sure that they're making good, equitable, rational decisions whenever it comes to all of the different resources that it takes to make sure that our healthcare system is as resilient as it can be. Another document that I wanted to share, and I'll let anybody ask questions if they have them related to that policy. This is a document, so I'll go on to this document. I really like this. This is something Dr. Lindscheit was able to create with our team. And this is basically what to do if you're a close contact. So if you are exposed to someone with symptoms of confirmed COVID-19, first, they're going to ask you, do you have symptoms? If you had symptoms, go get tested. You need a COVID-19 test, preferably a PCR, contact your physician, and isolate from others. So if you have symptoms and you're a close contact, go get tested and stay home otherwise. If you don't have symptoms, then you can test on days 3 to 5 after an exposure. And if you're fully vaccinated, wear a mask indoors in public for 14 days. If you're not fully vaccinated, then you really shouldn't be going out in public. If you're a close contact, you should really quarantine for 10 days and monitor your symptoms for 14 days. You can also get a test on day 5 or 6 and then return on day 7. So I thought this was a really nice explanation of what close contacts need to do. This is something that we're going to post on our website. It may already be up there actually, but this is something that we really want to make sure everyone kind of has a good idea, because we're frankly not getting to every contact and doing contact tracing in a timely fashion because there's so many people now. So we really need everyone in our medical community to understand at least the basics of contact tracing and what to do with people that are close contacts. And hopefully it's not that hard to figure out. If they're symptomatic, then get them tested. If they're not symptomatic, then if they're fully vaccinated, they need to mask indoors. And if they're not fully vaccinated, they need to quarantine. And then in terms of their positive, negative test results, again, we get asked this question all the time as well. If you're positive, assume it's a true positive and stay home for 10 days from the result of your positive test or from the onset of your symptoms. If you're negative and you're fully vaccinated, you can resume your normal activities. If you're negative and not fully vaccinated, you need to continue to quarantine. So hopefully that's clear. I thought that was really well done. The graphic design is just really great. So I just wanted to give kudos to Dr. Lindscheit and the communications team for putting this together. And we will try to get this posted so that you can share it more broadly or just have it up as a flyer or a handout that you can give to your patients. I think we're trying to get it translated into different languages as well. But this is just, a really quick way to guide people through a somewhat complicated decision-making process that will hopefully keep everybody safer. Any questions about that one? And people are asking, is this good for schools and employees? And the answer is yes. In general, I think we did it for schools to begin with, but it makes sense to do this for employees as well. All right. I'll just keep going and share a couple of more documents, if that's okay. And this one is pretty important, so I'll spend a little bit more time on it. This is our influenza order. So this is something that came out about a week ago. Hopefully you've had a chance to read through it. We're actually going to tweak it just a little bit to add in one line about religious exemptions, because we're getting a lot of questions about it. And I think that will give you some cover so that whenever you have questions about religious exemptions, that you can actually have a policy that aligns with what's already out there for religious exemptions related to COVID vaccines. So we really, we know that healthcare workers are under the COVID vaccine mandate through the state. This is a local mandate that we do every year for influenza. This year, we're adding in language to make it much more aligned with what the COVID vaccine mandate says, which is that, everyone's expected to do it. If you have a medical allergy or a strongly held religious belief, then you may be exempt from this order. And then if you do have a strongly held religious belief, we have another advisory about exemptions that we're going to link you to. So just keep that in mind. Otherwise, it's basically the same influenza order as last year. The color of the card is turquoise this year. And that's basically something that you can access on our website. If you have any questions, please let us know. But hopefully that won't be too big of a surprise because it's something that we do every year. In terms of what you do with people that aren't vaccinated for influenza, if they're not vaccinated for COVID right now, before September 30th, they're supposed to do a weekly test. With influenza, the weekly testing doesn't seem to be as high yield because influenza really is a symptomatic infection. There's really no such thing as a silent flu. In fact, that's one of the reasons why we were misdirected whenever COVID first came along, is because we assumed it was so much like influenza that people couldn't be silent carriers or pre-symptomatic carriers. Well, it turns out that's not true for COVID, but it is true for influenza, is that basically, if you have the flu, you're going to have some component of symptomatology. And so, if you're not vaccinated and then you come down with influenza, or even if you are vaccinated and you come down with a mild case, hopefully, then you're going to know on the first day that you're infectious and then stay home because of your symptoms. So hopefully that makes sense why we don't do weekly testing for influenza, but we do mandate that for COVID. Again, I know it doesn't answer every question you might have, but we do feel like this is another way that we can protect our healthcare workforce and all of our patients in our general community. We really encourage vaccination for anyone over age 6 months. And we did really great last year. So we just want to repeat the success of last year and just repeat our flu vaccination campaign and our public education campaign and really get people vaccinated for influenza this year. I'm already getting messages on my phone to come get my flu shot from my pharmacy. So this is something that we know a lot of pharmacies are getting the shots. Usually hospitals get them next, and then the health department gets them last. If you need help tracking down flu shots or getting your folks vaccinated for the flu, let us know. We do have some mass vaccination clinics planned, and I'll ask Sim to drop that in the chat because I know we have that flyer ready to go. And that basically will show you where people can go get a mass vaccination flu shot if they need one. Otherwise, you should be able to work with your vendors to get your flu vaccines as you do every year, and then offer, your flu clinics or whatnot. All right, I'll let everybody read through that while I read through the chat. Looks like there's some activity in the chat here. Okay, the badge color, I'm not sure where that came from. That was before my time. It's really a tradition. If the badge color or giving people a turquoise sticker or some kind of a mark that they've been vaccinated presents a huge logistical barrier for you, you're free to skip that step. We just want people vaccinated, whether they want to self-identify or not. Again, it was probably more important before COVID came along. Now it seems to be causing more problems than it solves because everybody's masked anyway. So, some hospital systems prefer badge colors, others don't or can't figure out how to make it happen with everything else going on. I understand that. We want to give you leverage and leeway to make whatever decision makes sense for you and your clinic. So just keep that in mind. We just want people vaccinated. The badge color is secondary. Obviously, when it's done well, it really does kind of build camaraderie and give people a sense of team unity. But we understand that takes a little bit of bandwidth and logistical investment. And we don't want that to be something that stresses you out and makes you lose sleep at night, among all the other things that you have to do. So we're happy to work with you. I don't know what OSHA says about the badges, Lance, sorry. But happy to review any websites that you could point us to. In general, we haven't heard any pushback about OSHA and badge identifiers, et cetera. And our lawyers looked at this flu mandate and they said it was fine. as to legal form. So unless there's a huge issue with it, I'm not sure that we're going to change it just because of OSHA. And I could spend a lot longer throwing OSHA under the bus, but I'm not going to delay everybody. Okay, the vaccination clinic schedule is in the chat as well. Please take a look at that. There are going to be drive-through events. There's going to be mass vaccination clinics. Another question that you're probably going to field from some people is, can they get their flu and their COVID shot on the same day or close to each other? And the answer is yes, absolutely. In fact, Moderna is thinking about, I just read this, I didn't have time to do a deep dive into the story, but I've heard Moderna is going to create a product that's combination COVID and flu vaccine. I'm not sure exactly when that's going to come down the line, but that just goes to show you that, a co-administration is totally fine. Obviously, do it in different arms or different parts of the body, and then give people good warnings that either one of those could trigger myalgias and flu-like illness. But it should be totally fine and will hopefully help you streamline your logistics. All right. Getting through this. And sorry, I'm just pulling up one more. A couple more interesting graphics just to talk about what's going on in terms of our forecasting, because I think that's another question everyone is really asking, is how much longer is this surge going to last? And what we're seeing is that, unfortunately, the Central Valley is going to have a surge that persists beyond what the other regions in California are experiencing. And that is shown best on this slide. This was the slide set that we presented to our Board of Supervisors on Tuesday. And this shows the R effective across California. So R effective is basically one number that tells you about whether you have spreading disease transmission or controlled disease transmission. When the R is greater than 1, it means that your disease transmission is getting worse. And the higher it is, the more it's spreading, the faster it's spreading. Ours happens to be just above 1, and it stayed above 1 as of this morning. The rest of the state has actually come down below 1. And so that's why I say that, the San Joaquin Valley region is going to have a surge that persists a little bit longer, because the rest of the state, their R effective is coming down and their case transmissions are also coming down, according to the state modeling. Unfortunately, we're just not there yet. We're really hoping that by mid-September, which is just a few days away, that we will eventually peak and then start to decline. And that, as the case rates decline, our number of hospitalizations decline. And even though ICU patients stay for a very long time in the hospitals, that eventually we will be able to reclaim a lot of our ICU space as well as this surge abates. That's certainly the best case scenario. I know it can't happen fast enough, especially because we're just coming up against influenza season and the winter virus season. And so those are all weighing on us as things to plan for. But just to share with you, we're probably looking at a few more weeks of surge-like conditions. All right. I think those are all of the graphics and items that I had to share. Let me see if anybody else wants to make any comments from the public health side. Anybody on our team, and then we'll just open it up to our Q&A. All right, I'm just looking through the chat here. Yeah, and that CalCat tool that Sim just shared is the one that we use for our projections. Someone is asking for the algorithm. I assume you mean the flyer that Dr. Lynchite created, and yeah, we will share that out, and we will get it posted online as well. I'm not sure what other algorithms you want us to share, but happy to help out. Okay, great. Thank you. We've also got Dr. Simon Paul, who's my colleague and the health officer at Madera County. Simon, do you want to just give us a quick update on what's going on across the river?
Not too much. Most of our numbers and situation is kind of the same as yours in Fresno. Maybe things are flattening out. It's hard to tell. Hospitals are all full. The only thing that, we sort of realized that our immunization numbers aren't high enough. They're not going to get high enough soon enough. And that really puts us at risk for ongoing hospitalization. So we're making a big push to increase the use of monoclonal antibodies for prophylaxis and treatment for early COVID. Because our sense is, even though vaccinations have doubled, we're still not going to get anywhere near to where we need to be in the near term. So there's a lot of people still coming down with COVID who still need treatment, and we're hoping, setting up an infusion center. We're working closely with Madera Community Hospital. We've got support from the state for nursing staff, which is the biggest shortage, to really try and ramp that up. Because I think the number needed to treat is like 15 or 20 to keep somebody out of the hospital. So, we're doing a huge amount of work to get one person transferred out of our ICU. And if we can just do 15, 20 infusions, that would have kept maybe 1 or 2 people out of the ICU. So that's I think the newest thing on our front.
Yeah, I totally agree. We've mentioned monoclonals many times on these calls. Dr. Zweifler has made a Herculean effort to corral and register and inform all of our monoclonal infusion sites about their options. But we continue to require, I think the demand is out there. I don't think enough people know about monoclonal antibodies or know about their value. So I feel like this is an underappreciated tool in the toolbox. And like you said, the number needed to treat is about 14. So it's really something that's worth looking into. Even with the Delta variant, I mean, there were some doubts about whether this new variant was going to be susceptible to the monoclonal antibodies. It turns out that the bamlanivimab, whenever it's given by itself, is really not it's really not good enough to tackle this Delta variant. But really, the Regeneron cocktail and some of the other cocktails, they all seem to have pretty good effects. So again, it's still a valuable tool in the toolbox, and it's just something that I think if more providers knew about giving them, they would probably offer them to their patients more. And logistically, it doesn't seem that hard. I mean, you don't need any special licenses or certifications. You just need someone that can start an IV and a physician that can supervise. And even if you don't have IV access, you can really even do subcutaneous. The pharmacokinetics is a little bit different, obviously. It seems to make more sense to do the subcutaneous if you are needing to do it in patients that are vaccinated, and then to do the IV, which really gives you a nice big peak of antibody concentration within an hour after the infusion, and to do the IV formulation for non-vaccinated patients. But either way, I mean, this is not rocket science. It's just another medication that you can give to patients, and you don't need to be an infusion center. We have primary care doctors. We have urgent care clinics. We would even like to set up a mobile site to do it, but we're just trying to figure out the logistics of that. In the meantime, like Simon said, we're asking the state for help. We're doing the same thing in Fresno County. We're just asking the state for help with, providing some kind of monoclonal antibody team. What about school outbreaks? Could you talk a little bit about that, Simon? Because I feel like you're really tracking this very closely.
Yeah.
How are things going in general? And then what do you think about the LA Unified mandating vaccines for all their students above age 12?
I mean, the school outbreaks for us, they're incredibly time consuming. I think the modified quarantine is working. What we saw was there's a ton of cases being brought in from outside of school, a lot from sports, from, the going back to school party. So kids show up with COVID. If they do the modified quarantine, especially if they have antigen testing on site and they get any infected kids out quickly, it's a huge amount of testing, but we only saw, very minimal spread within a classroom. And in some schools, we've seen no spread with a lot of cases in modified quarantine. They did over 500 tests and all were negative. But the problem is just the sheer volume of testing and paperwork required on the school's part. And, we get called, there's a lot of schools, there's an outbreak in this classroom, an outbreak in that classroom, in a different school, it's the football team, their siblings. So sorting each one out is just a massive amount of work. So how to manage that workload is the real question, because it's kind of unsustainable. But on a small level, if you can put all the resources into doing the testing and tracking out where everybody sat and all of that, it looks like actually the modified quarantines worked pretty well.
Yeah, I think you hit it right on the head. Don't send your kids to school if they're symptomatic. I mean, if people would just follow that one simple rule, that would really help curb a lot of the outbreak activity that we're seeing. We know that childcare is really hard to secure for a great majority of our population. So, I don't want to minimize how challenging that can be. But the fact of the matter is, when parents send their kids to school with the sniffles or the cough or whatever, it really creates a lot of animosity. We get a lot of angry emails about, why did the school allow this to happen? Blah, 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 blah. But beyond that, just from the human health and safety perspective, and not to mention that kid gets picked on, but from the human health and safety perspective, this is just an important step to remind your families and parents about. Say, just do that quick check-in with your kid in the morning and say, do you feel well enough to go? And if you don't, then it's okay to stay home or find some alternative options for them.
And again, sports teams are a real problem. They're large, 50, 60 kids on a team. So there's huge pressure on the one kid not to turn out to have COVID and have the team quarantined. I basically told them no sport is going to have a normal season unless their players get vaccinated.
Yeah, that's a great line. Totally true. And the sports guidance, I mean, again, we do deep dives into this and we don't need to belabor it on this call, but there is pretty complicated sports guidance out there. And it really dials down high risk activities versus low risk activities. And they divide out volleyball versus basketball versus swimming versus football. And everybody has a different testing regimen. So the state is trying to, calibrate risk as best as they can. I think that they are kind of overly dependent on rapid testing, which is, that comes and goes. And right now it's just not available. We're hoping it comes back online soon. But, when you don't have testing and when you don't have a vaccinated population, you're just asking for trouble. So I think that part of the consent process with these families needs to be any extracurricular activity that your kid participates in, even if it's outdoors, they're going to have indoor meetings. They're going to have, locker room time. They're going to go work out at the gym. And those are all higher risk activities, even if your sport is quote unquote outdoors, right?
Yeah, and that's what we're seeing. Every sport. It's not just football and the high risk ones, it's cheer, volleyball, cross country, because the kids all hang out before and after the sport.
Any other questions for Simon Paul? Thank you, Simon. Always great to hear from you. We'll try not to inundate Madera County with monoclonal antibody requests.
Well, we'll be ready.
I wanted to hear from Chris Staub and Patrick Sadler, if they're available, about how the blood center is procuring or distributing convalescent plasma. Sorry to just put you on the spot, but I think that links very well with this monoclonal discussion.
Hi, Dr. Vohra.
Hi, Chris. Can you talk about convalescent plasma? I mean, that's more of a polyclonal antibody, but it's the same concept.
Well, I like what you said earlier about with the infusion, you almost immediately have a high concentration of antibody present, and it's most likely a higher concentration than the COVID convalescent plasma we were giving out last year during the height of the initial waves. but we, in the second half of the term in which we were giving out this COVID plasma, we were required to use high titer only. But even so, I suspect you're right that the monoclonal infusions are superior to that.
Yeah, and presumably if someone survives the Delta variant, then they would actually have pretty good antibodies against the Delta variant. I mean, is that kind of the thinking? And do you know if that's actually panned out with the science?
I think that's the thinking. I have not seen anyone show that, scientifically to be the case just yet. But we've had one local physician ask us if we were going to resume collection of newly recovered patients, and so far we have not made a decision to resume collection. There's still some stock of the plasma collected last year. It's dwindling across the nation as it is being used, especially in the southern states. So the stockpile that was existing from last year is slowly disappearing. But other than one physician asking us locally, we've not had any pressure or opinion even to resume collection. So I'd be interested to hear what our other physicians and what you think we should do. There are other blood banks that have started, that have resumed collecting some of the newly recovered people. But what do you think?
Yeah, I mean, I think it's certainly worth exploring. My philosophy is that this is worth enrolling patients into like a pilot trial so that we can really investigate it fully and really invest the resources needed to really figure out how beneficial this is and select the right patient population for it. So I don't know outside of a trial whether this is something that's ready for prime time. But if one of our or several of our ICU groups wanted to study this as an investigational intervention, then I think certainly it seems plausible. There's definitely, the mechanism makes so much sense, and it would be a great way for people that survived to be able to help the community.
Yeah, I suspect if we decided on Monday to resume our program, it would probably take 2 to 4 weeks before we could actively recruit and collect and have new products available. But it's something we need to make a decision about soon.
Yeah, and I mean, honestly, you bring up another good point, which is that even when the surge ends, COVID's not going to end, and we really need to start playing the long game and recognizing that there's going to be, a subset of constant patients that just come into our hospitals with COVID or COVID complications. That's just, it's going to be with us for the long term, is what it seems like. And so we need to create processes that are efficient, evidence-based, and really get these people better as quickly as possible so that they're not sapping all of our resources, which is what seems to happen with these surges.
I don't know if Dr. Arakari, Pushpala Arakari is on the line. She was the one who had asked about it, and I think she practices at St. Agnes. I'm not sure.
Yeah, that's my understanding as well. Just looking through the list, and I don't see her. But yeah, she's an infectious disease specialist with an interest in this. And yeah, we can certainly reach out to her. It's a very interesting question.
But one of her comments was that she found it not so, the monoclonal infusion to be not so easily accessible, and that was one of her reasons why she asked about the COVID convalescent plasma.
Sure. Yeah, I mean, there's about 6 or 7 different clinics that are offering it now. And when I say clinics, I mean, primary care doctors, urgent care, even some of our subspecialists like nephrology and allergy specialists. And that list can be found on our advisory, which is posted online. But, it should be something that's very widely available. I really feel like that's the direction that we need to move in. It's hard to offer it, at the level of hospitals and emergency departments, just because the COVID testing takes so long and also the staffing shortages, which we've talked about extensively, really preclude that level of treatment to be offered. So that's the other problem, is this therapy doesn't seem to have a natural permanent home. And so then, like Dr. Paul said, we're kind of like just trying to gather some kind of a resource from the state just to help kind of plug these gaps. So, as we try to figure out what the long-term home for these infusion patients should be. Should they be an infusion site where they're going to be sharing chairs and airspace with immunocompromised cancer patients? That doesn't really sit well with most of us. Should it be an outpatient primary care site where an infusion can take 2 to 3 hours, and that's not really logistically efficient for those kinds of practices? So again, there's no great way to offer this medication, and I think that's what makes it challenging. But to their credit, a half dozen providers in our community have figured this out and have had really good experiences, and they've saved a lot of people just by offering these infusions. I know St. Agnes has been offering it for many months. I know that some of our outpatient partners have also done the same thing. So I think that's great. Hopefully, I remain optimistic that the science on this will keep advancing. And this really seems to be, even if different variants come up and we have to come up with different monoclonal antibodies to attack those variants, the technology is solid. And so I really feel like this is going to stay as part of the armamentarium for COVID patients for the long term.
Well, thanks for that. Dr. Vohra, I'll talk to you next week a little bit more about our plans with CCP.
Oh yeah, sure. Thank you so much. And as always, a good reminder to have everybody donate blood and have their patients donate blood, because I'm sure that that's always a constant need for the blood center.
Thank you so much.
Sure. Okay, well, we're winding down the hour. Is there any other question or topics that that anybody else wants to bring up?
Hey, Dr. Vohra, it's Lance. I wanted to address the question I posted in the chat about why Fresno County hasn't followed suit with other counties by implementing another mask mandate. It's working in San Luis Obispo County. They're very strict there, and their numbers reflect that it's effective.
Well, that's a great question. It's really something that we've advocated and tried to fight for very hard here. Unfortunately, it's something that our governing body, the Board of Supervisors, doesn't agree is necessary at this time. And they obviously have a lot of pressure on them from different constituents and populations that are adamantly against mask mandates. So that's the balance that had to be struck. And unfortunately, we just didn't get to have a mask mandate passed. I mean, we tried really hard this last board meeting this week. That's the answer in a nutshell, Lance. I think outside of that, whatever we can do to promote masking by educating our patients and by leading by example, and then using other platforms that we have with our staff, with our social media, whatever other influence we can have, certainly we need to exploit those. But as it stands today, Fresno County is just not ready to have a countywide mask mandate. I know that really saddens me quite a lot, and it's caused me a lot of turmoil in the last couple of weeks that we weren't able to get that done, because we all recognize the value of masking, but unfortunately the skeptics don't, and they're really making a big stink, and so our elected officials are quite confused about where to go next. I think they all do agree, though, that vaccination is important. So I feel like, if anything, if there's a silver lining here, what they messaged to us was, we can't get behind masking right now, but we definitely can get behind vaccinations, and we're going to do whatever we can to help promote vaccinations. So I said, that's fine. Let's work on something that we can agree on, and really try to get vaccinations promoted as much as possible. So I think that's kind of where we landed.
My only other question, Dr. Vohra, is when do we expect at least the Pfizer vaccine to be eligible for children?
Yeah, good question. I see that horizon as still a couple more months away at least. And it may not be before Thanksgiving or Christmas, based on what I've read and the comments that I've heard from the federal authorities. And that's just because the trials, they do need to mature a little bit more. And then the research needs to be vetted at the FDA. Hopefully they will, put that on double time and speed that up as much as possible. But they do have to wait a certain number of months and then look at both arms of those trials in order to determine that, they're safe and efficacious. I think we know what the answer will be, so it is kind of frustrating that we do have to wait. But it's the right thing to do, and it's the proper way to proceed. So I think they are going to allow that plan to continue. Hopefully in the next few months we'll hear about that. I think even sooner we're going to hear that Pfizer boosters are going to be okay for those who have 8 months or longer on their timeline since their last Pfizer shot. So if your second Pfizer shot was 8 months ago or longer, then you're going to be eligible for a booster. And that's going to start later in September. I mean, they've kind of penciled in a timeline of like September 20th. So that's something that you're probably going to be fielding questions about as well. And that's the answer is, if you had Pfizer and it's been 8 months, then you're probably going to get eligible for a booster starting in late September. That leaves out Moderna, that leaves out Johnson & Johnson. And they basically also said, wait to hear about Moderna and Johnson & Johnson, but probably very similar timelines on those vaccinations as well. So remember, Pfizer was the first one that kind of was available in the US. So it makes sense that that booster would be approved first, and then Moderna and then Johnson & Johnson will probably follow afterwards. And then I think they are going to try to honor the 8-month timelines in as much as they can, just because that's kind of what the best science right now shows. And the boosters is something that will be available on My Turn as well. So whenever people ask you about boosters, you can tell them the same thing. Just go on the website. It's called My Turn, and they will allow you to register for a booster shot in your neighborhood, and then you can just register through that website. All right. Well, I think we're winding down the hour. Great questions, great discussion. Thank you so much for speaking up, Simon and Chris and everyone else. Let us know how we can support you. Remember to take care of yourselves, and hopefully we can continue the conversation next week. Have a great weekend.